bacteria. So for the pathophysiology, upper eye, here you can see a table of the classification of nephrolithiasis. So the most common component of urinary calculi is calcium, which is a major constituent of nearly 80% of all stones. So calcium oxalate is the most common in the calcium-containing stones, while uric acid and struvite are the most common in non-calcium-containing stones. This is another table that shows the diagnostic classification of nephrolithiasis. So most classification systems differentiate stones on the basis of the underlying metabolic or environmental abnormalities that they are associated with. So they can either act alone or in combination, and we'll try to go through them briefly in the next few slides. So for calcium stones, these are the different abnormalities that would predispose to formation for calcium stones. So first, hypercalciuria. So hypercalciuria is defined as greater than 200 milligram urinary calcium per day after adherence to a 400 milligram calcium, 100 milligram sodium diet for 1 week. This can also be defined as a greater than 4 milligram per kilogram per day excretion of calcium, or more than 7 millimole per day in men and more than 6 millimole per day in women. So this is the most common abnormality that is identified in calcium stone formers, and it is because the high urinary calcium can lead to increased urinary saturation of calcium salts and also decrease in inhibitory activity. So calcium transport is regulated at 3 sites: the intestine, the bone, and the kidneys. So dysregulation at any of these sites could lead to hypercalciuria. And in 1974, Pak et al. Divided the hypercalciuria by its 3 distinct unique pathophysiological abnormalities. So first is absorptive hypercalciuria, which is due to an increase in intestinal absorption. And then next is renal hypercalciuria, which is due to a primary renal leak of calcium. And third is resorptive hypercalciuria, which is due to an increased bone demineralization. So first, let's talk about absorptive hypercalciuria. This is defined as an increased urinary calcium excretion after an oral calcium load. And the pathophysiological abnormality is that the increased intestinal absorption of calcium would result in increased serum calcium. And this would suppress the serum PTH and result in increased renal filtration, which leads to hypercalciuria. So despite this increase in intestinal absorption, this is matched by enhanced or increased renal calcium excretion, and therefore serum calcium levels would remain normal. So this is caused by both vitamin D independent and dependent processes. For renal hypercalciuria, this is, so the kidney filters approximately 270 millimole of calcium and reabsorbs more than 98% of that, and more commonly in the proximal tubule. So in renal hypercalciuria, there is impaired reabsorption of that calcium. So that would lead to increased urinary calcium levels and ultimately to secondary hyperparathyroidism. So serum calcium levels would remain normal because the renal loss of the calcium is compensated by increased or enhanced intestinal absorption of calcium. So also by bone resorption, and therefore high fasting urinary calcium levels with normal serum calcium levels are characteristic of renal hypercalciuria. So CASR, or the calcium sensing receptor, is the main sensor that is involved in this. Resorptive hypercalciuria is an infrequent abnormality and is most commonly associated with primary hyperparathyroidism. So when there is excessive parathyroid hormone, as is the case with parathyroid adenoma, this leads to increased bone resorption. And this increases the renal synthesis of calcitriol. So increased which enhances the intestinal calcium absorption and thereby leads to increased serum and urine calcium, as well as decreased phosphorus levels. So they administer a diuretic, and this would enhance the renal calcium reabsorption, and exacerbate the hypercalcemia, which is without suppressing the PTH production. So this would facilitate the diagnosis of calciuria. So there are also hypercalcemic induced hypercalciuria. It can be through these different mechanisms. So first, from sarcoid or granulomatous disease. So macrophages in the sarcoid granuloma would synthesize 1-alpha hydroxylase, and therefore, since it produces calcitriol, would increase calcitriol and enhance the absorption of calcium and promote bone resorption. Malignancy-associated hypercalciuria is actually the most common hypercalciuria in main cause of hypercalcemia, in hospitalized patients. So it's because tumors would produce a PTH-related protein which acts like PTH and therefore similarly would increase renal calcium absorption. So the most common malignancy to present with this is lung and breast cancers, followed by renal cell, head and neck, and hematologic malignancies. Lastly, glucocorticoids would promote bone resorption and reduce bone formation, which would ultimately lead to osteopenia with chronic use. So aside from this, they also stimulate release of PTH and decrease intestinal absorption of calcium. For hyperoxaluria, this is defined as an urinary oxalate level greater than 40 milligrams per day, because this leads to an increased urinary saturation of calcium oxalate and subsequent promotion of calcium oxalate stones. So oxalate has also been implicated in crystal growth and retention, and membrane injury would facilitate the fixation of calcium oxalate crystals and its growth. So for hyperoxaluria, there are 4 different causes. So it can be from disorders in the biosynthetic pathways or primary hyperoxaluria. It can be due to intestinal malabsorption, like enteroxaluria. It can be due to increased dietary intake or high substrate levels, or dietary hyperoxaluria, and it can be from idiopathic hyperoxaluria. So for primary hyperoxaluria, this is a result of rare autosomal recessive inherited disorders that are in the glycoxylate metabolism, where normal conversion of glycoxylate to glycine is prevented. And this leads to preferential oxidative conversion of the glycoxylate to oxalate. So the markedly high levels of urinary oxalate that occur would lead to increased saturation of calcium oxalate and formation of calcium oxalate complexes. So there have been 3 forms of primary hyperoxaluria, or PH, that have been identified. So PH1 is due to a problem with the pyridoxal phosphate-dependent alanine glycoxylate aminotransferase, or AGT. So this is synthesized in the liver peroxisome. So mutations of this would lead to elevated levels of oxalate and frequently glycolate. So this is the most aggressive type of primary hyperoxaluria, and end-stage renal disease occurs in this kind. As for PH2, this is associated with a defect in the glycoxylate reductase hydroxypyruvate reductase, or GRHPR, in the liver. So this is less aggressive than PH1. And then PH3 is a 3rd type, which is caused by a defect in the mitochondrial enzyme 4-hydroxy-2-oxoglutarate aldolase, or the HOGA. So the mechanism for why this leads to hyperoxaluria has not yet been established. So the second type was the enteric, again, hyperoxaluria, which is the most common cause of acquired hyperoxaluria and is associated with chronic diarrheal states because the fat malabsorption results in saponification of fatty acids with divalent cations like calcium and magnesium oxalate complexation and increase the pool of available oxalate for reabsorption. Next is the dietary hyperoxaluria, which is due to overindulgence in oxalate-rich foods, such as those seen on your screen. So in addition, severe calcium restriction can actually result in reduced intestinal binding of oxalate, which would increase the intestinal oxalate absorption. So ascorbic acid supplementation has also been shown to increase urinary oxalate levels, while a decrease in the Oxalobacter formigens causes more stone formation. And lastly, idiopathic hyperoxaluria. They have suggested that mild hyperoxaluria is an important factor as hypercalciuria is in pathogenesis of idiopathic calcium oxalate stones. So the abnormalities in the metabolism and transport of oxalate can contribute to the nephrolithiasis. So for hyperuricosuria, this is defined as a urinary uric acid greater than 600 milligrams per day and occurs as an isolated abnormality in around 10% of stone formers, while in combination around 40%. So most commonly this is caused by an increase in dietary purine intake. However, acquired or hereditary diseases like gout or thalassemia can also contribute to this. The mechanism for this is that the increase in the hyperuricosuria has been shown to increase monosodium urate, which in turn promotes calcium through both heterogeneous and epitaxial crystal growth. Has been shown to absorb naturally occurring macromolecules of crystallization. This reduces effectiveness nucleation of calcium oxalate. However, some have process of salting out, which is a process whereby the solubility of calcium oxalate in solution is decreased by the addition of another salt. Hypocyturia is an important correctable abnormality that is associated with nephrolithiasis, and this is because citrate is an important inhibitor, as was mentioned earlier, that can reduce calcium stone by complexing with calcium, agglomeration, and protein. So hypocyturia 20 milligrams per day. The primary whereby metabolic acidosis would reduce tubular reabsorption and decrease synthesis of citrate. So there are also several causes. So distal RTA, I'll talk about later. Chronic diarrheal states would also cause intestinal alkali loss in the stool. Excessive animal protein intake can provide an acid load, thereby reducing citrate levels. Diuretics like thiazide would induce hypokalemia and intracellular acidosis. Angiotensin-converting enzymes can cause hypercyturia by systemic acidosis or hypokalemia, and strenuous exercise can induce lactic acidosis. Low urine pH, so at urine less than 5.5, the undissociated form of uric acid would predominate, and this leads to uric acid and or calcium stone formation. So calcium oxalate stones form as a result of heterogeneous nucleation with uric acid crystals, and any disorder that leads to low urine pH may predispose to stone formation. So in chronic metabolic acidosis, the low urine pH, the hypercalciuria, and the hypocyturia can all lead to this. So renal tubular acidosis is a clinical syndrome which is characterized by metabolic acidosis that results from defects in the renal tubular hydrogen ion secretion or bicarbonate reabsorption. So there are actually 4 types of renal tubular acidosis, but today we'll just be talking about type 1, type 2, and type 4, with type 1 being the most significant neurologist. So acid-base balance is maintained by the kidney through several mechanisms that involve the proximal and distal nephron. And a defect in either bicarbonate reabsorption or acid excretion can lead to metabolic acidosis. So this is an image of the proximal renal tubule. So filtered bicarbonate is almost completely reabsorbed in the proximal renal tubule through an indirect mechanism involving hydrogen secretion. So the carbonic anhydrase in the tubular cells would generate hydrogen and bicarbonate and thereby provide hydrogen ions that are secreted into the tubular lumen by the sodium hydrogen exchanger. So sodium that is pumped out of the proximal tubule by the sodium potassium ATPase is what drives this exchanger. Luminal hydrogen ions would combine with the filtered bicarbonate in order to form H2, just rapidly converted in by carbonic anhydrase into water and carbon dioxide, which can diffuse back into the cell. So the net effect of transepithelial bicarbonate absorption, the net effect is absorption without causing hydrogen secretion or a significant change in urinary pH. As for the distal nephron, this is the site where net elimination of hydrogen is from 5 to 10%, and is reabsorbed here. So hydrogen binds with urinary buffers such as titratable acid like phosphate and ammonia, and allows a net elimination of hydrogen in the form of ammonium. So this hydrogen excretion occurs through the active secretion of the alpha intercalated cells through an hydrogen ATPase and a hydrogen potassium ATPase exchanger. So these cells also have a chloride bicarbonate anion exchanger that transports bicarbonate into the blood. So these active pumps would generate 1,000 to 1 hydrogen ion gradient between the cell and the tubular lumen, which allows reduction of urine pH to as low as 4.5. So in type 1 distal renal tubular acidosis, this comprises a syndrome where there is abnormal collecting duct function or inability to acidify the urine in the presence of systemic acidosis. So the classical findings would be a hypokalemic, hyperchloremic, non-anion gap metabolic acidosis, along with nephrolithiasis, nephrocalcinosis, and increased urine pH. So the most common stone composition that is associated with this is calcium phosphate, and this is due to the hypercalciuria, hypocytruria, and increased pH. And while metabolic acidosis would promote bone demineralization, which leads to secondary hyperparathyroidism and hypercalciuria. So profound hypocytruria is the most important factor in stone formation in this setting due to impaired citrate excretion as a result of the metabolic acidosis. So distal RTA can be hereditary, idiopathic, or acquired, and again is due to a dysfunction in the type intercalated cells. For type 2 or proximal RTA, this is characterized by a defect in bicarbonate reabsorption and is associated with initial high urine pH that normalizes as plasma bicarbonate decreases and the amount of filtered bicarbonate falls. So with reduced capacity of the proximal tubule to reclaim the filtered bicarbonate, more bicarbonate is delivered to the distal tubule. So this distal tubule has limited capacity for bicarbonate reabsorption, and therefore bicarbonaturia would occur, which results in reduced net acid excretion and metabolic acidosis. So nephrolithiasis, however, is uncommon in this type of RTA because there is relatively normal urinary citrate excretion. And type 4 distal RTA is associated with chronic renal damage, such as seen in patients with interstitial renal disease and diabetic nephropathy. So the reduction in glomerular filtration includes kalemic hyperchloremic metabolic acidosis, which is caused by loss of bicarbonate in the urine and decreased excretion of ammonium. So this is also associated with aldosterone resistance because aldosterone contributes to stimulation of distal acidification and hydrogen potassium exchange, and renal stone formation in this type is also uncommon. For hypomagnesuria, this is a rare cause of nephrolithiasis and affects less than 1% of stone formers as an isolated abnormality. So magnesium would complex with oxalate and calcium salts, and therefore low magnesium leads to reduced inhibitory activity and decreased urinary citrate levels, which further contributes to stone formation. So this is more commonly caused by decreased or poor dietary intake of magnesium, as well as decreased intestinal absorption, as is what occurs in chronic diarrheal syndrome. For uric acid stones, on the other hand, most mammals, except us humans and Dalmatians, would contain uricase, which catalyzes the acid to allantoin, or the end product of purine metabolism. So because we lack this uricase, we accumulate significantly higher levels of uric acid in our blood and urine. So uric acid is a weak acid, and the proportion of its free uric acid is what determines our risk for stone formation. So urine pH is the critical factor that determines uric acid solubility, and at low urine pH, this is thought to be a risk factor for uric acid, calcium oxalate, and mixed stones. So there are three main determinants of uric acid stone formation, and it is low urine volume, low urinary pH, and hyperuricosuria, with low urinary pH being the most important. So low urinary pH, uric acid stone formers excrete less acid into the urine as ammonium and proportionately more titratable acid and less citrate in order to maintain normal overall acid-base balance. So this impairment in ammonium excretion has been linked to uric acid stone formers and linked to a insulin resistance state. So they found that patients with more triglyceride, patients with hypertriglyceridemia, hyperglycemia, obesity, and hypertension, or the characteristics of metabolic syndrome, were found to share the same characteristics as uric acid stone formers. So this mechanism by which insulin resistance leads to low urine pH has not been completely formulated. However, it can be due to because insulin promotes renal ammoniogenesis from glutamine and also stimulates the NHE3 in the proximal tubule, therefore leading to ammonium trapping in the urine. So in impaired ammonium production or excretion as a result of insulin resistance, this could leave hydrogen ions unbuffered in the urine and therefore lead to a reduction in the urine pH. So next, hyperuricosuria, as again was defined earlier, can cause supersaturation of urine with respect to sparingly soluble undissociated uric acid, while low urine volume increases the risk of uric acid supersaturation, especially in workers with hot temperatures. As for cystine stones, under normal conditions, amino acids are freely filtered by the glomerulus and almost completely reabsorbed in the renal proximal tubule. So cystine is transported across the apical membrane of the renal proximal tubule and jejunum by sodium-dependent heteromeric amino acid transporter, or HAT. So cysteine is a dimer of two cysteine molecules that are linked via a disulfide bond, and its solubility is much less than cysteine. So it is reduced intracellularly to cysteine, which provides a favorable gradient for its reabsorption. So there are several factors that determine the solubility of cysteine, and this includes cysteine concentration, which is the most main contributing, and different urinary macromolecules like colloid. So for infection stones, these are primarily composed of magnesium, ammonium, and phosphate, and may contain carbonate apatite. So this was found by a Swedish geologist who named it after his mentor and called it struvite. And they also isolated Proteus vulgaris, which is a urease-producing bacteria. So for the pathogenesis of this, because urease is not present in sterile human urine, infection with urease-producing bacteria is a prerequisite for the formation of infection stones. So urea, a constituent of normal urine, is hydrolyzed to ammonia and carbon dioxide in the presence of urease. And then the alkaline urine that results from this reaction favors the formation of ammonium. Under physiological conditions, the alkaline urine would prevent further generation of ammonium. However, because there is the presence of urease, ammonia would continue to be produced, which further increases the urinary pH and also promotes the hydration of two bicarbonate and hydrogen. Then further dissociation of bicarbonate would yield carbonate and another hydrogen ion, until finally the dissociation of hydrogen phosphate under alkaline conditions would provide phosphate and thereby complete the constituents for infection stone formation. So for bacteriology, the family Enterobacteriaceae makes up majority of the urease-producing pathogens. However, there have been other gram-positive and gram-negative bacteria that have been found to do this, and they attributed this to its ability to damage the mucosal layer of the urinary tract, which increases the bacterial colonization and crystal adherence, with ammonium enhancing this risk even further. Infection stones only account for around 5 to 15% of all stones, but they are the most common component of staghorn calculi and are more common in women and these populations. So lastly, for miscellaneous stones, xanthine and dihydroxyadenine stones were found to be autosomal due to autosomal recessive disorders of purine metabolism. So an XDH deficiency leads to accumulation of xanthine, while an APRT deficiency leads to accumulation of adenine, which is turned into DHA by XDH. So these stones are highly insoluble and radiolucent and can be mistaken for uric acid stones. Allopurinol, which also inhibits XDH, has been found to predispose to xanthine stones, although this side effect is quite uncommon. Ammonium acid urate stones represent around 1% of all stones and are also radiolucent and are found in patients with these disorders. So the underlying pathophysiological mechanism for laxative abuse is that it would decrease gastrointestinal fluid, and that would lead to dehydration and eventually intracellular acidosis and increase in ammonia excretion. So aside from this, laxatives also decrease the urinary sodium, and therefore urate would complex with abundant ammonia and lead to urinary supersaturation. For matrix stones, there have been found an association with urinary proteins and stone formation such as osteopontin and calprotectin, which form the matrix structure of urinary calcium stones. So these kinds of stones are quite rare, and they're also radiolucent, so they can be mistaken for uric acid stones. For medication-related stones, drugs can either induce precipitation or crystallization directly or indirectly by altering the urinary environment. So these are the different kinds of drugs that can affect this. The ones that directly promote are the antiretroviral agents, triamterene, guaifenesin, and ephedrine, and silicate stones, while those that indirectly promote would be corticosteroids, vitamin D, phosphate-binding antacids, because they induce hypercalciuria, thiazides because they cause intracellular acidosis and subsequent hypohydraturia, loop diuretics, which inhibit sodium and calcium resorption, carbonic anhydrase inhibitors, which block resorption of sodium bicarbonate, topiramate, which also inhibits carbonic anhydrase, laxatives, as was mentioned earlier, and cytotoxic. So for the second to the last topic, anatomic predisposition to stones, with anatomic abnormalities have been shown to increase stones either by increasing urinary stasis or by their metabolic abnormalities. So ureteropelvic junction obstruction, they found that this treatment of this obstruction would lead to reduced recurrence rate of stones. For horseshoe kidneys, they have a 20% rate of renal calculi, and this can be due to the high insertion of the ureter into the renal pelvis, which causes impairment of renal drainage and predisposes to ureteropelvic junction obstruction. So calyceal diverticula stones are associated with 40% of these patients, and it can be due to both the urinary stasis and underlying metabolic abnormality, while medullary sponge kidneys would have nephrocalcinosis and renal calculi as frequent complications. So for stones in pregnancies, the last topic, symptomatic stones occur at a rate of 1 to 250 to 1 is to 3,000, and majority occur in the second to third trimester and are heralded by the onset of flank pain and hematuria. So around 90% of pregnant women present with physiological hydronephrosis, either due to progesterone or the compressed ureters by the gravid uterus, and dilation occurs more commonly in the right than the left ureter, which leads to urinary stasis and crystallization. So the physiological changes that occur in pregnancy is first, renal blood flow would increase, which increases the glomerular filtration rate by 30 to 50%, which increases the filtered load of calcium, sodium, and uric acid. Aside from this, placental production of calcitriol increases intestinal calcium absorption and suppresses the PTH. And lastly, there is increased excretion of inhibitors like citrate, magnesium, and glycoproteins. So for the key points, absorptive hypercalciuria is characterized by normal serum calcium. Renal hypercalciuria is due to impaired renal calcium reabsorption. Resorptive hypercalciuria is due primarily to primary hyperthyroidism. And the most important determinant of uric acid stone formation is low urinary pH. So this is because impaired ammoniogenesis can be a result of insulin resistance and excess acid production. So in the distal renal tubular acidosis, there is a defect in the hydrogen ATPase, and formation of infection stones would require alkaline urine that can only be achieved with a urease producing bacteria. So thank you.
Thank you, Dr. Hinga ka muna. So that's very detailed. Basically, physiology lang naman yun. And yung management. So, Doctora, for example, somebody came to you, a 26-year-old female, PGI, who likes to work out and goes to the beach, and then presents to you with an ultrasound into the incidental finding of a sub-centimeter stone. So, let's say 0.5. So, anong una mong gagawin based on your report? So, do you see risk factors first for her?
So exercises a lot po, or
yeah.
Well, that
goes
can
to the beach.
be goes to the beach.
Based dun sa first 10 slides mo.
So for the hot climates po can predispose to stones.
So meron na, no? May risk factor.
Yes.
Email, okay. So what would you advise this patient?
Well, since it's small pa, we can try just increasing the fluids, maybe try to help it pass through po. And,
so how much? By how much? Output. So you can ask them that. What else? Dietary modifications.
Oh yes, if depends on what they're eating po. Yes, so we can ask about that.
Yeah. So how about, and then bumalik sa'yo. So you did a repeat ultrasound, and then you found out there's the stone. So you plan to do on medical expulsion therapy. So which medication would you give for it? So first muna, what's the most common stone that you can find in this patient?
Well, the most common is calcium oxalate po.
Yeah. Okay, so what would you give? What's your goal of management for this patient?
To reduce the calcium and
how about
and
the
oxalate.
pH?
So you can.
What can you do?
So we have to alkalinize the urine.
Yun yung hinahanap. By? So paano? Anong pwede medications na ibigay mo based on your report?
We can give thiazide diuretics. Or
pwede. Yung pinakakailangan, ano ba yung nagbabind sa calcium?
The oxalate.
No. Hindi. Sinabi mo na kanina. Di ba yung citrate?
Okay, yeah, we can give citrate as an inhibitor po.
Yeah, so yun lang naman yung point ko based on your report. Yung next reporter ba next week, more clinical? Ano bang next reporter sa Wednesday?
Doc, ano po? Surgical anatomy of female pelvis.
So parang tapos na tayo sa stone pala. Medyo basic lang naman yung kailangan. Yung mga surgical hindi. So very good, Dr. Camila. So ilan? Isa lang? Ikaw lang, Dr. Murphy?
Kasama ko po si Bajola. Dalawa po po.
Wala pa akong may nag-send na ba kayo ng PowerPoint?
Di pa, Doc. Send na lang kami later. Sige po.
Anong mahaba ba? Hindi naman.
Mahaba po siya sa book. Pero try namin i-shorten.
Sige. Attendance lang tayo. Tapos okay na. Thank you, guys. Dr. Camila, thank you.
Thank you, sir.